Hey everybody, let's talk about Chapter 11, all about falls. So the definition of a fall by the World Health Organization is an event that results in a person coming to rest inadvertently by accident on the ground or floor or other lower level. The American Nurses Association defines falls as an unplanned descent to the floor with or without injury to the patient. Now, the incidence of falls, well, falls are the second leading cause of accidental or unintentional injury deaths worldwide. Isn't that amazing? Risk of injury from falls is highest in people over 75 years of age. Now, I want to say here that at 75, they're at risk for falling, right? So let's say you're at a facility and you're working and you've taken fall risk precautions on your patient. And then a family member comes in and says, hey, why do you do that? Why are you doing acting like my loved one is going to fall? And you're just going to say, hey, everybody over the age of 75 can fall. And in fact, it only takes one fall. And then after that, they're going to continue to fall. It's just a way that it progresses. Falls progress. You fall once, you're going to keep falling. Older adults constitute only 12% to 13% of the total U.S. population, but they account for 72% of deaths as a result of falls, and 2/3 of those deaths a result of falls, and they were preventable. So we want to prevent a fall. So what are some risk factors? So let's turn to page 181, and it talks about risk factors. So there are intrinsic and extrinsic factors that are involved. Intrinsic factors mean the functioning of the individual, the way they are. It could be an illness, so it's something that's within the patient. Extrinsic falls are environmental, so it's going to be something that's on the outside that caused them to fall. Intrinsic factors enhance the possibility of falling. Extrinsic factors enhance the opportunity to fall. Now, falls are the most frequent cause of accidental injury and death among older adults, but the important intervention is fall prevention. So we want to prevent a fall from even happening if we can. So let's look at table 11.1. It talks about intrinsic factors. So those would be things like, now you have a little bit different listing than I do, so I'll kind of look at both. Reduced vision and hearing. So it talks about reduced visual acuity and impaired dark adaptation. So it gives you interventions of how to be sure that they have their glasses on or their hearing aid on, and to encourage eye exams so that they are up to date on their vision tests. We always want to leave a light on. So I always like to leave a light on in the bathroom, even if you close the door a little bit, so at least that crack of light can come out so the patient can see their way to the bathroom. Age-related changes in posture and gait. So musculoskeletal disorders, they cause balance and gait. And also balance disorders. Provide and educate the patient on the use of assistive devices. Avoid alcohol, that can cause some balance loss. Peripheral neuropathies from diabetics. So we want to be sure they have on good shoes, not those flimsy slippers. You can also have the socks with those little stickies on the bottom that keeps your patient from slipping. Also, foot disorders. So be sure their toenails are trimmed. Encourage the patient to wear the right footwear and get podiatry care. Now, there's always an order in the chart for a patient to have a podiatrist see them, and some facilities have a podiatrist come about once a month, and they need an appointment to be seen because, you know, those toenails, as we have talked about in earlier chapters, they're hard, they're yellow, they're really thick if you've noticed. So they're hard to cut. So I wouldn't risk cutting toenails. Get them to a podiatrist, let them cut. And of course, we know we do never, that doesn't sound right. We don't ever cut toenails of diabetics. So confusion or depression, so it could be medication that they're on that has caused them to have confusion, and maybe they are depressed and they just kind of lag and drag their feet. A lack of exercise leads to weakness and decline in physical vigor. Multiple medications related to increased incidence of chronic illness in older adults. So like hypertension. So they're on hypertensive meds, but we know that always dangle your patients before you get them up. So don't take them from a lying to a standing position because they have orthostatic hypotension. It could be from medication. It could be from hypovolemia. So be sure you dangle your patient before you get them out of bed. And that will decrease the incidence of loss of balance or weakness or that postural hypotension where they get dizzy and lightheaded. Psychotropic meds, if they take something to help them sleep or some other medications that keep them groggy, that can make them stumble to the bathroom or fall out of bed, reach for something and not be able to get it and then fall out of bed. Acute infections, so that can affect their body, the way they think, how well they feel. So they might have trouble getting what they need and fall out of bed or just fall from weakness. Diseases affecting the central nervous system may affect balance by causing dizziness and gait disorders. For instance, stroke. Now, if you notice on that table 11.1, it lists stroke. And it says, place the call bell in the visual field. Now remember, visual field. So they might have a loss of peripheral vision. So it needs to be really right where they know where it is. Some people even pin it right to their gown so they know where that call light is. Take their hand, have them touch the call bell so they know where that is. Always keep it within the reach of the unaffected arm. And we're going to talk about this a little more, but so if they've had a stroke and their left side is affected, their right arm can move, right? So put their call light on the right side where they can reach. Always have their bedside table on the right side and close to them so they can reach. We don't want them crossing over their body trying to reach the table and losing their balance. So that's really important to remember. An overestimation of abilities. So, people don't want to admit that they're getting old and they're losing their faculties, they're losing their abilities. So they overestimate. They say, I can do it, I know I can. And they try and they can't. So that is an intrinsic factor because the person thinks within themselves that they can do it. They overestimate their abilities. So some extrinsic factors. On page 185, it talks about that as well, and especially patient teaching. It's the patient teaching box on page 185. So low-lying, poor visible tables. So this is if they're at home and they're trying to get to the bathroom from their bed and there's a table in the way. But because they're looking forward, they don't see a table below their line of vision. Also, electrical wires on the floor, extension cords, little pets, they kind of skittle across the floor, and the elderly maybe didn't see them or hear them, because remember their hearing and vision is fading. Steep and unlit stairs could be a problem. So patient teaching is going to teach about, be aware of these things. Loose carpeting, throw rugs. Well, the patient teaching for that is don't even have it. Get rid of those loose carpets and throw rugs, because you know how they bunch up, and then you can trip over them. Slippery or slick floor. So a shiny floor is slippery. And we always want to have good lighting so that the patient can see their way. There are lights that you can get that fit like into the wall sockets around the floor that light up the floor. That's a really good thing to have that you can buy even at Target, and that helps light the flooring. It's even good for us, you know, we get up in the middle of the night, you're a little groggy, you can't see that well, you stumble to the bathroom, maybe you've had a drink or two. Good lighting on the floor can really help, right? And I trip over, my dog is brown, and we have a brown floor. I trip over him all the time, and it's a German Shepherd. You'd think I'd see him, but you know, I'm so focused on where I want to go, and I just walk straight, and then I trip over the poor thing. It can happen. All right, factors that increase the risk of falling. So the first thing you got to know is that if you have a history of falls, you are going to fall again. And that's going to be one of the first questions that you talk to your patients about when you admit them. Have you ever fallen? Now, they may not want to admit it, so we always know that we go to the family as well. And sometimes the family doesn't know either. But a history of previous falls can lead to other falls. And that first fall can be life-threatening, and so can future falls. You know, you bump your head, it can lead to a subdural hematoma without you even knowing. Because what if you're on a blood thinner, right? And you fall and bump your head, you can have a bleed. Osteoporosis, weak bones. So we want to install a grab rail in the bathroom or the shower by the toilet so that they can pull themselves up. Home health will help be responsible if you're sending your patients home, and they can help maybe get a lift for the toilet so the patient doesn't have to go down so far to the toilet. Hemiparesis. So again, I'm going to say place items on the unaffected side so they don't have to reach over and try to find what they need on their bedside table or the cord or a rail to turn. Sensory impairment. Their senses are poor, whether it be seeing, hearing, feeling, and if they've had a stroke, all those, or other injury, they are going to have sensory impairment. Diminished muscle strength, balance, reaction time. And I threw this word in, ataxia. This is another one of our words we need to learn about. So what is ataxia? Well, it's a poor walk. It's not an inability to walk, but it's not a straight walk. It's kind of a stumbling walk. Diabetes with peripheral neuropathies. Now, these peripheral neuropathies, they don't feel their feet sometimes. They don't know where their feet are. They don't know when they step on something. You can have a Lego there and they can't feel it, and then they fall because they lose their balance because their foot is on something that they're not even aware of. Loss of consciousness or falls on a hard surface. And multiple medications. There's multiple medications that can put the risk of falling. So let's talk a little bit about restraints. So we've talked about, if you go to page 187, before we go to page 182, I just want to show you there's some fall prevention techniques used in hospitals and long-term care facilities. And those are important to know. And some of them I have already mentioned. But that's a really good box. Especially since you're there, let me tell you some important things to know. Place the nurse call light within reach. That's under environment-oriented techniques. And also, I already mentioned, place safety grab bars in the bathroom and hall. So even as they walk down the hall, holding onto a rail can prevent a fall. Encourage the use of the bathroom and corridor handrails. So those are really important under box 11.3. And box 11.2 has the Hendrick 2 fall risk model, and that rates a patient how much they are at risk. And there's another scale we're going to talk about as well that puts the patient at risk. Continuing on, though, from that fall prevention guidelines for the home, it was on page 186. So activity: get up from a chair slowly. When getting out of bed, sit and wait 1 to 2 minutes. That's that dangling that we're going to do with our patients so that they can, their ability to equilibrate themselves, their blood flow and their blood vessels to get equal, their blood volume. So we want them to dangle for about 2 minutes. And then another important thing is use alcohol and tranquilizers with caution. So you may want grandma to take a nap or to go to sleep, but don't give her too much alcohol. And remember, there's alcohol in NyQuil, and there is some medication that has alcohol in it. So if they have liver disease or kidney disease, we want to be careful about giving anything with alcohol. And also the tranquilizers. I'm going to be talking about this on this page here under restraints. Xanax. So if you're looking at under chemical restraints, Xanax is a psychotropic drug. It's also listed under using alcohol and tranquilizers, as I said, with caution. Well, Xanax is an example of that. All right, so let's get back to the slide at hand. Sorry, but I want to point you to places in the book, and they're not always exactly where we're talking, but at least I'm going to make you aware. So bear with me if we bounce around a little bit. It's always for your benefit. So restraints are often used to prevent falls. Wrist and ankle restraints may be made of soft material or leather. I hope not leather. Maybe in a psych facility. What are the most common incidents precipitating the use of restraints? Well, let's talk about when we use restraints. Well, we're going to use physical restraints, especially if they're at harm to themselves. That's when we would use a physical restraint. Are they going to harm themselves? They may not mean to. I had a patient, I think I talked about it before, with mad cow disease. We had to put him in 4-point restraints because he was at risk for hurting himself. He was going to lash out, hit people, anybody that came near him. His focus wasn't good, so he was hitting himself even, hitting people, hitting the side rail, so he could have hurt himself. Well, that was a good time to use a physical restraint. So if they're at risk for hurting you or themselves or another patient, a restraint might be a consideration. So what is a restraint? It's anything that restricts movement and cannot be released by the patient. So there's a special knot that I'm sure you learned in Skills Lab. Physician's order. You always need a physician's order for restraints, and that order must specify the duration and the circumstances under which the restraints may be used. So that would be because the patient's at risk. Maybe they have an IV in, and you don't want them removing that IV. So that's the patient's putting themselves at risk by taking their IV out. So you might have to restrain that arm. But again, need the doctor's order. And we're trying to prevent a life-threatening fall. A remove and release restraints. Now this is really important to remember. remove and release restraints every 2 hours for 10 minutes, but don't leave them. For those 10 minutes, you need to stay with them to be sure that they don't get up or pull that IV out or hit you. So just stay with them. Maybe you would have someone else with you as well so that you can hold that arm down. You are going to be stronger than them. And then during that time, that 10 minutes, provide range of motion. So you're going to take a hold of a joint, not like the forearm or anything. You're going to take a hold of a joint and do a range of motion, up and down, back and forth. And then also we want to check the patient frequently when they have a restraint on. And that would be every 15 to 30 minutes. I know that seems like a lot, but you know, there have patients that got tangled up in restraints. So we need to keep an eye on them, and we need to have a doctor's order. Okay, I'm repeating myself, but it's important. So let's talk about chemical restraints. Well, never use psychotropic drugs for the purpose of discipline or convenience. So I had a case for the state where a nurse, so a patient was a little bit restless, didn't really want to go to sleep even though it was bedtime. So the nurse brought him out to the nurse's station. Well, that was a good idea. They were in a wheelchair. They could keep an eye on the patient. But the patient still kept trying to get up, and the nurse was trying to get her charting done. So what did she do? She took this patient into a back room, had 2 CNAs hold her down, crushed the medication, put it in liquid, and forced it with a syringe, like a big G-tube syringe, and forced it down her throat. Now that's force. Not only was that chemical restraint by using medication, but it wasn't ordered to be crushed, so she made a mistake there. And a mistake by holding the patient down physically. You can't do that without an order. So she made several mistakes. I think she lost her license there. So please be careful. Use chemical restraints only when danger of self-injury or injury to themselves or others. So you might have to sedate someone. Haldol is a famous one that we use when they're combative. Administration of a psychotropic drug requires a physician's order, written order, that specifies the duration and circumstance under which the medication is to be used. For instance, let's say it's Haldol. So Haldol 1 milligram IM if patient combative. Use Q8 8 hours PRN if needed. So it's going to have to be a whole order. And then another example of a chemical restraint is Xanax or Prazolam. Anything that ends in an am, like Valium, you know, it's going to be a sedation type of a drug. So Xanax is a chemical restraint because it is a medication that we use on purpose to make them go to sleep. Now, a sleeping pill is not the same thing. Sleeping pill is an order from the doctor to give to help the patient sleep. Because if you've ever taken a sleeping pill, sometimes you just can't stop the thinking. Now, I use meditation to help me go to sleep rather than a sleeping pill. But sometimes you can't stop your head. You can't stop the thinking. All right, let's go to the question. So which of the following is not true about injuries and falls? So let me give you a minute. It's pretty long answers. Remember that word not in there. So the answer is C. So why is it C? Well, let's look at the answer. Falls occur in older adults. Well, that's true. Only because of intrinsic factors. That's not true because there's intrinsic and extrinsic factors. So be sure you read the whole answer, because the rest of that answer is factors related to the functioning of the individual, such as the aging process or physical illness. Well, there's other reasons. So falls occur in older adults because of intrinsic factors or factors related to the functioning of the individual, such as the aging process or physical illness, and extrinsic factors or environmental factors. And remember that C, the reason it's not right, because I bet you're looking at it going, hey, wait a minute, that seems true to me. It says only because of intrinsic. Well, falls occur in older adults not only because of intrinsic factors. There's other reasons. The extrinsic factors, right? So remember, intrinsic and extrinsic factors. So box 11.1, I pointed to you. I guess I've done that before, didn't I? Well, there's tables and there's boxes. So let's go to box 11.1. Where's that? I'm trying to find it. Sorry, you can probably hear me turning my pages, can't you? Well, that's weird. There isn't a box 11.1. There's a table. Oh, there it is. There it is. There it is. 11.1, page 184. Sorry, I guess my eyesight isn't as good as I thought it was. All right, so some alternatives to physical restraints. Well, physical therapy. Let's make them stronger. Let's increase their muscle strength. Teach them how to go up and down stairs. Physical therapy can really be helpful. Sitting and talking with patients for short periods. Sometimes they get up and go looking for someone to talk to. So an alternative is sitting and talking with your patient, calming them down, finding out what's on their mind. Also asking staff to be responsible for wanderers in small blocks of time. So sometimes people get up and wander in the middle of the night. We've got to be on the alert for that. And if you look up and you see a patient wandering, you go, that's not my patient. Please don't think that, because everybody is your responsibility. We have to be careful for everybody. I remember one time when I worked for an insurance company, and I went in to talk to the patient, find out how they were doing, to be sure that they met the criteria for being in the hospital. And the patient happened to say, oh, I need to use the bathroom. Well, there was a nurse right outside the door on the computer. So when I left, I said, the patient in this room needs to go to the restroom. Could you help them? And she goes, that's not my patient. Please. That's not a good response. All right. Another thing, alarm bracelet. Ambularm is another name for it. You might see that somewhere. So there is in box 11.1 on number 9, it says enroll patient in safe return program that includes identification device with contact information. I have had a patient leave the facility, did not have an ambularm on, and ended up at Walmart. So they do wander and they do leave. So having a bracelet like that, I don't know how they ended up finding where that patient belonged, but they must have asked the patient. Maybe she finally was with it enough to answer. So read through the alternatives to physical restraint, good information, and always remember about the ambularm. So fall prevention. The most important intervention for falls is prevention. If you can prevent the fall, you don't have the problem. The best prevention is education of the patients and caregivers. So mention to your patient, I'm going to leave the light on for you to see your way to the bathroom, if they're able to do that. Or be sure they know where their call light is. And it's important that they call you and not get up by themselves. And sometimes we have to repeat ourselves, right? With some of our patients with dementia, we have to keep repeating ourselves. Their caregivers need to be educated. They might not know about the throw rugs or the lighting that can fit into the plugs. So we can help the caregivers have knowledge. Knowledge is power. It helps prevention. Prevention should be aimed towards minimizing intrinsic and extrinsic factors causing falls and the potential for injury. The first step, determine who's at risk. And again, that's when a patient comes in. Right away, the minute you meet a patient, you can determine if they're at risk. And if they're elderly, if they're 75, they're at risk. Because that's what we learned, right? Fall prevention strategies are carried out in the home and institutional environments. Again, I'm going to tell you a little instance here of a patient who, I guess he had fallen at home before he got admitted to the facility, but they didn't tell the nurses. They kept that information from them. So remember, they don't always tell the truth. That's a family member even. So the patient got up out of bed and fell to his knees. Now, luckily, he didn't hurt himself, but he did fall. So the facility instituted fall prevention strategy, and that included putting the bed against the wall so they couldn't get out one side, and the side that they could get out of, they had a rubber mat. Maybe you've seen that in some facilities. So that's to reduce them getting injured when they fall. So the facility did a great job in that instance, but what happened, I'll tell you the rest of the story, is that the patient had a history of heart disease and ended up having a heart attack that killed him 3 days later, but the family still tried to sue the facility because they said the fall put such stress on him that he had a heart attack. But he didn't really hurt himself, so the facility was okay. It wasn't a problem. But, you know, California, sue-happy state. So you might keep that in mind, unfortunately. I also am going to lead you to box 11.3, which is fall prevention techniques used in hospitals and long-term care facilities. So you can take a peek at that. I think I already had you come to this box once before, but it fits in here too. So remember those 3 things: the call light within reach, be sure the patient can use it properly. You know, some patients have such weakness, especially I had a patient with multiple sclerosis, she couldn't push a call button. She didn't have movement of her fingers. So she had a pad. So she just tapped the pad and that called the nurse. So sometimes we have to make special circumstances. Also, place the grab rails in the bathroom and the hallway, and encourage the use of bathroom and corridor handrails. All right, reducing fall-related injuries. So individuals at risk for falling also can be taught to rotate. So if they do fall, how do we reduce that injury? Well, we want to teach them that if they do fall, rotate forward or backward to avoid falling sideways. Reduce the risk for hip injury. So if they feel themselves falling, maybe they want to rotate forward or backward. Now, are they going to hit their head? I hope not. But it does reduce the risk of hip injury. Now, there are hip pads that they have, some facilities have, to prevent hip injuries, but they're very uncomfortable and they're sticky. They stick to the skin and then they can cause skin injuries. So they're not used very often. Measures to prevent osteoporosis may reduce the risk of fractures associated with falls. How do we do that? Well, we want to give vitamin D, calcium, get it in their diet or in medication. Exercise. So walking can be muscle strengthening. So even if it's you doing the exercising of their extremities or them doing it. And remember, there's isometric exercises too. Just tighten and relax, tighten and relax. And that can help get them stronger. So what do you do when a fall occurs? Let's say you're working nights and you hear a crash and you walk in and you find the patient on the floor. We'll determine the circumstances of the fall and any injury. So you're going to kind of scan the area. What do you think happened? Did they slip on something? Was there water spilled and they slipped on that? Is the patient hurt? I had another story here. Patient who had just had an amputation, but they forgot. And you know they have the phantom limb. So he forgot that he didn't have a leg. So he got up and fell. And of course the stitches broke open. So when the nurse came in to the fall, not only did she see the person on the floor, but she saw blood all over. So that can happen too. An IV gets pulled out with a fall, or they get injured and they bleed. So you're going to have to assess the injuries. Document the fall according to the agency protocol. Document, document, document. It's going to cover you. Note what the patient was doing at the time. Were they trying to get out of bed? Were they reaching for something? What was the mental and emotional status of the patient at the time of the fall? I know afterwards they're probably going to be crying and upset that this happened. It's very embarrassing to fall. Any environmental fall factors that may have contributed to the fall. So were the sheets on the floor? Did they trip on the bedspread? Remove or correct the cause. Have the patient ambulate as soon as possible and at least several times a day. And part of that is not only to get their strength, but also to, once you've fallen, you're afraid of falling again. So it's just like if you've been in a car accident, you want to get back in the car if you're not injured. But, you know, if you're in a fender bender, it's traumatic to get back in the car because you're afraid it might happen again. Well, it's the same with a fall. So get the patient ambulating as soon as possible. Show them that they don't have to fall. Show them the things that they can hold on to. And at least several times a day in order to prevent the hazards of bed rest. So we don't want them to regress and get weaker. Plus, it restores their confidence. Oh yeah, I can walk. I am strong and I'm going to get stronger. So when a fall occurs at home, so the patient needs to pull themselves up using steady furniture. So if they have to crawl to a chair to pull themselves up on, it may require cooperation of the person who is at risk, the family, and possibly neighbors. You know those little things that hang around the neck, and they push the button and it can call the neighbors to come, or they can, if they have Alexa, they can call, Alexa, I need help, call 911 or something like that. There's a lot of modern things that have come about since this slide was written. Plan of action should include information about getting up and seeking help. So tell them what to do the next time this happens. Hopefully it won't, but if it does, what do we do? And let's get that button you can push for help, or call Alexa, or call 911. Devices worn around the neck, that's what I was talking about. They can send signals to a control center are effective and provide the feeling of well-being for the individual. So I wanted you to notice the patient teaching box, and that is on page 188. So that has some good information. The roll onto your right side, crawling, roll to a prone position and get up on all fours and crawl where you can get a hold of something. Shuffling, put yourself to a sitting position on the floor and shuffle on the buttocks. And then the stair shuffle. So those are all ways that can prevent falling at home. So this is just a reminder. Last slide. The least restrictive device is the best. Check your patient frequently, at least every 15 to 30 minutes. And if physical restraints are necessary, they should be removed every 2 hours for 10 minutes. Please put that in your head. All right, thank you.